Great. So thank you for inviting me to talk to you this afternoon. I'm taking you back to postpartum pathways. I know my colleague Kath Tucker spoke earlier this morning, and also a bit of a change of gear in terms of presenting you some qualitative data. So firstly, I don't need to give this audience any details on the background and the significance of preeclampsia and the long-term effects that it has for mothers and babies and also the wider families, and understanding kind of the long-term causes and the postnatal ramifications are really a really important part of this jigsaw. We've been studying the risk of postpartum care for a number of decades now, and thinking about women's behaviour and understanding of their risks and their health-seeking and help-seeking behaviour is something that has been significant for the last 20-30 years. I dug out this paper from the mid-1980s, which is looking at why women do or don't present at a medical facility. We're really interested, and we recognise the significance of understanding women's behaviour and responses to preeclampsia and hypertension in pregnancy. So just as a bit of a reminder, I know that this audience and this meeting has been tracking our emerging development of this evidence base over the last few years, and myself and Rich McManus and Kath Tucker have spoken to you many times over the years as we have developed this this evidence base. We ran the BUMP 2 trials, which concluded in 2019, and the main papers were published in 2022. And in addition to the trials which were published in JAMA, we also conducted through the course of those trials a number of qualitative studies and evaluations to understand women's experiences of self-monitoring of blood pressure and their experiences of the shifting of responsibilities potentially from health professionals to the individual. So the paper on the top left here is a paper that we published looking at the information that women are presented with in the normal course of a pregnancy around monitoring for blood pressure during their pregnancy, and we tried to unpick in that paper their responses to this shift in responsibility for self-monitoring during pregnancy. And risk and responsibilization more broadly in heart disease and cardiovascular risk is something that is obviously having wider attention. And the paper on the right there is a paper that looks at responses to understanding risk and individual responsibility more broadly in cardiovascular health. While we've been developing the evidence base around self-monitoring of blood pressure in pregnancy and now in the postpartum period, we have also been through the significant health system shock of the pandemic and the shift to remote provision of care during 2020 and 2021, which has arguably accelerated the evidence base for self-monitoring and self-responsibility. I've put details up here of a paper that I collaborated with many people on this meeting, in this meeting today, and colleagues, looking at the shift to remote antenatal care during the pandemic, in which we developed a quality framework for thinking about the provision of remote antenatal care. And we very much view self-monitoring and self-monitoring supported by mobile apps as part of the jigsaw in that remote antenatal care. So the evidence has been building, and the evidence has been broad in terms of both highlighting the advantages and the benefits of remote care, but also highlighting some of the equity issues that also need to be considered when we're thinking about shifting care towards individuals. And I'll pick up on that a little bit later in my talk. So that's the context. I know that Kath will have talked to you earlier today about the work that we're now developing, extending the work that we did in the BUMP trials to the SNAP-2 trial, which is looking to optimize the management of blood pressure following a hypertensive pregnancy. So very much focusing on the postnatal period. And what I want to talk to you about this afternoon is some in-depth qualitative work that we undertook just over a year ago as part of the development for that trial. We wanted to really drill down to understand what care women receive in the postnatal period after hypertensive pregnancy, who is responsible for delivering their care after they are discharged from hospital and where that care is delivered. How does that get done and why it happens in the way that it does? So we undertook individual interviews and also some focus groups conducted by telephone and also video over Teams and Zoom. We recruited a sample from across the UK and interviewed and conducted focus groups from around June, July through to late September last year. We spoke to a total of 44 women ranging from age 18 to 49, and we were very focused on making sure that we had a really varied socioeconomic and ethnic diversity for reasons that you will appreciate in terms of the poor outcomes in maternal health more broadly. So we were very pleased with the range and the richness of our sample of women that we spoke to. 23 were white British. We had 4 Asian and British, and then 13 Black women from Black African, Caribbean, and Black British backgrounds, and 4 from mixed multiple ethnic backgrounds. We also spoke to 32 health professionals drawn from Manchester, London and Midlands and the Oxford and Thames Valley area. And here we wanted to make sure that we were speaking to both obstetricians and hospital midwives and also community midwives and GPs. And we had a good range of responses there and did individual telephone interviews with all of these health professionals. In analysing the data, I have been drawing on some sociological theories, which might be kind of a new idea to this audience. Sociological theories around nothingness and responsibilization. So there is a very interesting sociology around both silence, invisibility, and nothingness, which might sound like it's got very little to do with postnatal care after hypertensive pregnancy, but I hope I'll be able to demonstrate where I see the links and be very happy to answer questions at the end of my talk. So in terms of the findings, we found that at a very top level, the care of women with hypertension following discharge from maternity services was often haphazard, despite women remaining with approximately double the subsequent risk of hypertension and cardiovascular disease for at least the next 20 years. The health professionals that we interviewed described postnatal care following a hypertensive pregnancy that was provided in their local area, and we have identified common pathways with some variations area by area. So this slide is a collation and a sort of distillation of all of the care pathways that we heard from the health professionals and the women who told us about the care that they had received. So after delivery, women often spent 2 to 5 days on a postnatal ward, and their medication was adjusted according to NICE guidelines, although obviously with local variation. They were then discharged, often between 2 and 5 days with medication. A discharge summary or a BP pro forma was sent to the GP and a copy given to the women, although I should say that there was a great deal of variation in terms of both the quality of those discharge summaries and whether they did or didn't get through to the GP. The midwife would then follow up in the community for the next 10 days, either by telephone or in person, and check blood pressure, and ideally ask the woman to contact their GP for review. the lines that I have in green here are then the actions that the woman was responsible for undertaking. So it was her responsibility to contact her GP in those first 2 weeks post-discharge for repeat prescriptions of medication and a review of her blood pressure. She was also told in some situations that she could contact maternity services for advice for up to 28 days after delivery. She would then present to the GP for the 6 to 8 week postnatal check. Although some GPs offer this check, they often do not contact the women before the 6 weeks unless the woman has contacted them about their medication. And then in some cases where women had severe pre-eclampsia, they were followed up through cardiology services. So that's a distillation of what the women and the health professionals we spoke to described to us. And here are some key themes that came up out of the interviews. So there were significant gaps in this care pathway that were identified. There was often poor communication of information between secondary and primary care services about blood pressure management following hypertensive pregnancy. Information that was communicated either to the community midwives or the GPs was often highly variable, and those discharge summaries were in some cases excellent and in some cases either too scant in terms of their information, or the significant information, the important information about hypertension was lost in the midst of a whole lot of other maternity-related information from the woman's pregnancy. And even with the discharge summary or letter, there was uncertainty from obstetricians and from their perspectives as to whether the GPs had received the information and were able to act on it. There were information gaps and information overwhelm. So British birth discharge summaries historically focus on the birth and midwifery aspects. Some health professionals we spoke to felt that they were lacking in terms of medical input about hypertension. Often the information could be inaccurate or not detailed enough on the hypertension aspects of the woman's pregnancy, and didn't clearly highlight an obstetric plan or a medication plan and identify clear targets for down titrating. It was also unclear as to who was responsible for the care of these women. And I'm just going to take a minute or so to read you out these quotes, because I know it's often hard when quotes are flashed up on a screen, particularly on a remote conference. So on the right here, we've got a quote from one of the community midwives that we spoke to. So she said, "There's a lot of frustration from the woman going in if she's got kids at home and a newborn baby. You're kind of chasing them to see if you should go in or not. You feel responsible for that woman's care if she's not going to take care of herself. I know it's her responsibility as well, but..." So a real sense that community midwives knew that the responsibility was in theoretically with the woman to contact her GP and arrange her medication, but she was uncertain as to whether the woman had the brain space and the energy and the time to do that. And in terms of the GP's perspective, on the left here, GP said, "I've had several experiences of women coming to see me postnatally, either for their routine or 6-week or 8-week check. And before that saying, 'What do I do with this?' She's got a box of labetalol and I say, 'Oh, well, what's that? What's happening? Is the hypertension midwife following you up?' 'No, well, I rang her and she said, I'm stable now, so I'm discharged and to speak to you.' But I've not had any communication for that team." So then it's usually a sort of bit of scrambling to try and find out what to do. So both of these speak to those gaps and that handover from secondary to primary care being less than smooth in some circumstances. I like to think of these perspectives as silos, and there are consequences for these silos. It means that in lots of cases that the care rests with the individual woman and the responsibility rests with the individual woman to explain her diagnosis and medication plan. And that could lead to miscommunication and delay, and of course, a lost opportunity for long-term health. And as this obstetrician said here, the bottom quote, "Pregnancy is the window into your long-term health. All of these metabolic conditions, cholestasis, gestational diabetes, pregnancy-induced hypertension, they all predict later disease. As an obstetrician, you don't care about that, but you just care about the woman safely delivered, a healthy mum, a healthy baby. So that obstetrician's very much speaking to the fact that from her perspective or their perspective, that their responsibility stops with the woman once the baby has been born and they've been discharged. And then the GP says, I think women are very conscious of their blood pressure in pregnancy. I'm not sure that they're so aware of their continuing to be an issue postnatally in pregnancy. I'm not sure that they're aware of it continuing to be an issue postnatally. I don't know that women necessarily understand the relative of hypertensive disorders in pregnancy and the consequences on their future health. So there were concerns about the extent to which women were really understanding the consequences and the significance of the responsibility that they've been given in this postnatal period. The women spoke to us and described a sense of feeling a bit lost in terms of taking responsibility for this care. They talked about the significant shift from being closely monitored during their pregnancy to having that level of care significantly reduce, and for then becoming responsible for self-managing and the management of their blood pressure. Some women were clear who they should contact at each stage, whether it should be the community midwife or the GP, but others were less clear whether the care was just for their baby and also for themselves. They talked about their experiences of changing from being closely looked after during pregnancy by hypertension maternity specialists who were obviously able to provide detailed advice on medication to the generalist care of their GP, where often the GPs feel unconfident about managing hypertension in the postnatal period. Some had absolutely had good experiences and felt confident and supported, but others had received mixed messages and felt a lack of trust in their GP care. I just want to, as I wrap up here, draw another kind of link to the equity issues here. I'm sure all of the audience today are acutely aware of the maternal inequalities in the UK and the findings from many of the Embrace reports around the women who are most at risk of poor outcomes, who face a constellation of biases in terms of the disadvantages that they face. So in terms of shifting and thinking about the specific care that I've outlined in terms of postpartum care for hypertensive pregnancy, I think this background is really important. And it's one of the things that we have been thinking very closely about in developing the intervention to get it ready for trial, and then also thinking about the design of the trial. So in terms of the intervention development, we've thought very carefully about access to phones and apps, how to generate trust in the intervention. We've been considering issues around language barriers and also making sure that the intervention is very clear in terms of its signposting, because we're aware that people will have varying knowledges of the health system and care pathways. So we've woven all of those thoughts into the development of the trial, the development of the intervention and the preparation of the trial. And I'm sure some or all of us will be back next year to tell you a bit more about how that is developed. So thank you very much. I'll stop there.